a need for better phenotyping of patients, and a more specific talk by Dr. Fervenza when he shares his slides. So we're very excited today to have our speaker, Dr. Fernando Fervenza.
Thank you very much, Dia. So these are
Excellent.
my disclosures. They are here. And I like to make one disclosure. All right. I think for years, I mean, people are just saying FSGS as a diagnosis. And I think what I like try to convince you again is that FSGS is not a diagnosis. FSGS is a lesion that is found on a kidney biopsy. Now, and the many reasons for why a lesion, a focal segmental glomerulosclerosis appears, and that may be because this patient has primary FSGS, maybe because the patient has secondary, maybe because the patient has a genetic disease, or maybe because the patient just got a biopsy because he had been ANCA vasculitis 20 years ago and now comes with proteinuria and he's in remission. You do a lesion, you find a lesion, FSGS. But I think it's important that we understand that this is not a diagnosis. And why is it important? Because if you don't proper phenotype those patients and you put them all in the same bag, then we are not going to make any progress, because I think I try to convince you if there is one that is going to need immunosuppressive therapy or is a candidate for immunosuppressive therapy are the patient who had what we so-called presumed primary FSGS, while the others are not. They are going to be candidates for either conservative therapy or whatever. And also, finally, just touch base on when do we do genetic testing in those patients. So this is what I was trying to say, that FSGS is not a disease, it's just a pattern of injury. In fact, this is a Glasgow slide, and it's not a specific disease. And it can resolve by a wide array of pathogenic process. And we're trying to convince, at least in the United States, that you, just like microscopy, not enough. You have to do electron microscopy to require a full evaluation. I like to be provocative, and the first thing I like to say is that even the name of this business is wrong, because it says focal segmental glomerulosclerosis, but that is based on the fact that if you do a biopsy, here you have 5 glomeruli, all right? And you can see that at least 2 of those glomeruli are very good, all right? They are all normal, but this one has a scar, and there's one that maybe has a scar too. Then you say, oh, is focal because of this, but all the others are good. Well, then how are you going to convince if you do a biopsy? Because we go to the patients and we say, if the patient has primary FSGS and they don't go into remission, then in like 5 years, at least they are likely to be on dialysis, the majority of those patients. But then how do you convince a patient? If the patient goes to you, he has a biopsy, you say, well, you have 20 glomeruli in the biopsy. Only 5 of those show the scars. The other are all good. But if you don't go into remission, go to dialysis, the patient is going to say to you, but wait a minute. Only 5%, 5 of this glomeruli, the other 20, the other 15 are good. Why I'm going to dialysis? Because it's misleading. When we say that it's focal, in primary FSGS, it's not really focal. And this is a study that Andrea Ramuzzi, the cousin of Beppe, did back in 1995. I was a fellow at Stanford when he came as a visiting professor there in Presentis, and it struck me that's an interesting observation. This is a glomeruli. Remember, the glomeruli from top to bottom has about 200 microns, and when the pathologist does the cut, he cuts about 2 microns. You can easily see that while are you cutting here, if you cut in half, you are not going to find anything. You're going to look normal. It's only when they did pictures and pictures of each section, and then they did a computer 3-dimensional reconstruction that showed that in reality, the majority of the glomeruli have the lesion. Now, I talk to this, I present this to, but this to to Agnes Fogo at Vanderbilt. I talked to Sanjeev Sethi at here at Mayo, and they don't believe that. All right, but and of course I have to do a disclaimer. This is an animal model, all right. But what is true is the following: is because you see, this is I like to say this because I think the devil is in the detail. In the old days, all right, This is what Sanjeev tells me, like a few weeks before. In the old days, the biopsy was very limited. They would cut 3 sessions of the biopsy or 4 sessions of the biopsy, and then look at that. And that is all logical that you do. And in fact, Agnes published this. I didn't put that. And she did, when they reevaluated those biopsies and did extra sessions. In fact, they improved from finding 30%, they improved like going to 50%. And Sanjeev now saying that in a normal, at least at Mayo Clinic, when they do a kidney biopsy, they do like 60 sections. So the fact that when they look, yes, if you just do 3 or 4, or if you do that the old days, they would do 3 or 4 sections, you are going to miss. And if you do multiple sections, you are going to improve. But they said you're not going to be 90%, but it's going to be like 60%. The bottom line is that